A very good evening to all my viewers. So today let's discuss about a very important topic, that is Mullerian anomalies, which has been frequently asked in various forms in not just entrance exams but also in your MBBS final year as well as in postgraduate MS exams. To understand this topic, you need to understand the embryology, that is the development of the Mullerian system, and then the most important part is the update, that is the classification. Different societies have given the different type of classification, which is very important to understand. And then the clinical features and management you can understand if your concept is clear. So in this video I shall be discussing only about the embryology, the development, and the classification, the update. In some subsequent video I will be talking about the clinical features and management. So before starting, let me introduce myself. I am Dr. Sonali Jagati, Senior Resident, Obs and Gynae Department, SCB Medical College and Hospital, Cuttack, having secured an All India rank of 3546 in NEET PG 2021. So let's begin with the development of the Mullerian system. For that, first we need to understand the embryology development. So once the zygote is formed after the fusion of the sperm and the egg, on day 5 there is the formation of the blastocyst. Okay, the blastocyst contains the trophoblast cells and the inner cell mass. So if you see, it has outer trophoblastic cell and an inner cell mass. Okay, so this is how your blastocyst looks like. Okay, then this gives rise to the inner cell mass over here of the blastocyst, and this is your cavity, and that is why it is known as blastocyst. Cyst means a cavity or a space. Okay, so blastocyst is the day 5 embryo which contains the outer trophoblast and the inner cell mass. The inner cell mass will give rise to the embryoblast. Embryoblast is, if you see, how does embryoblast form? So here, this is the embryonic disc. Embryonic disc starts forming in between and divides this blastocyst cavity into two cavities. One is amniotic cavity and other one is yolk sac. This embryonic disc is also known as embryonic plate. This is trilaminar in origin. That means it contains ectoderm, endoderm and mesoderm. Okay. This mesoderm again has extraembryonic mesoderm and intraembryonic mesoderm. Okay, so remember, this intraembryonic mesoderm is the one which gives rise to the urogenital sinus. Urogenital sinus forms the urogenital ridge. This urogenital ridge gives rise to two ridges, that is, or two lineages you can say. It forms the nephrogenic part and the genital ridge. Okay. Genital ridge will give rise to your gonads, that is testes or ovaries. Nephrogenic ridge will give rise to the urinary system. Remember, after around 60 days post fertilization, from the nephrogenic part of the urogenital ridge forms the mesonephric kidneys and the mesonephric ducts. Mesonephric kidneys will further develop to form metanephric kidneys. Remember, metanephric kidneys are nothing but your mature kidneys. So we can also call it as simple kidneys, which are the mature kidneys. Next comes your mesonephric ducts. Mesonephric ducts will form the ureteric bud. Then ureteric bud will form the metanephric ducts, which are nothing but the ureters. Okay, and then they form the metanephros. Okay, so remember, finally the mesonephric ducts are giving rise to the metanephros. This metanephric ducts, okay, near this is what develops your paramesonephric duct, that is known as the Mullerian duct. Okay, so this is where the point lies, and this is very important to understand. Why am I emphasizing on the development of the nephrogenic part, or why am I highlighting on the development of urinary system? Because our paramesonephric duct, which is also known as the Mullerian duct, develops closely in relation to the nephrogenic ridge. Okay, so these metanephric ducts and the metanephros lie closely to the Mullerian ducts. So any Mullerian anomaly, whenever you suspect, always analyze and evaluate the urinary system also. And this is a very important point to remember. There is usually sometimes some anomaly in the urinary system associated with in that patient also. So this is why understanding the embryology becomes important. All right. So after you have understood this, remember that paramesonephric duct, also known as the Mullerian duct, develops from the invagination of the coelomic epithelium almost at the 6th week of intrauterine life. And as I said, they lie near the mesonephric ducts. So in this diagram, you can see these are your gonads, okay? They develop from the genital ridge. So keep them aside for now. And now you have the Wolffian duct, which I have drawn in green, and the Mullerian duct, which I have drawn in pink. Okay. So depending on the chromosome of the patient. Now, suppose the patient is XX. That means it's a female. So they don't have any SRY gene. Okay, SRY gene is located in the Y chromosome. So if that is not present, there won't be any testes. Okay, so no testes means there will be tendency to form the female genital system. Okay. So there is the Wolffian regression when there is no SRY gene and no formation of testes. Now there are certain genes which are required for the ovarian development. As I have already written, they include WNT4, WT1, FOXL2 and DAX1. Okay, these are important for ovarian development. Now for the Mullerian development, we have WT1, WNTT2, okay, WNT2, PAX2, PBX1 and HOX genes. Now these are the genes which are required for the Mullerian development. Okay. So in toto, these genes which are required for ovarian development and Mullerian development help in the further, in toto development of the female genital system. Now Mullerian and Wolffian both appear roughly around 6 to 7 weeks. In female, there is the lack of AMH, that is the anti-Mullerian hormone, which is secreted by the Sertoli cells, which are produced from the testes. Okay, so since female lack AMH, the Wolffian will regress by around 9 to 10 weeks and the Mullerians will persist. HOX A9 will give rise to the fallopian tubes, whereas the HOX A10 and A11 genes will give rise to the uterus. Okay, next important point to remember is the urogenital sinus. Okay, now this is the lower 1/3 of the vagina, which is formed by the urogenital sinus. The upper 2/3 of the vagina is formed by the Mullerian system. Urogenital sinus again can be divided into cephalic, middle and caudal part. Okay, so this is something that you have to remember. So by the fusion of the Mullerian system with the urogenital sinus, that takes place around 10 weeks. And remember, it is always a caudal to cranial fusion, and this gives rise to the uterovaginal canal. This has to fuse, okay, and if again there's any fusion defect, that will also give rise to Mullerian anomalies, which we'll see later. Now, once the Wolffian is regressing, it also leaves behind some of the remnants in the female. Okay, what are the remnants of the Wolffian system in the female? We have the upophoron, which is the organ of Rosenmuller. Okay, this is the other name of upophoron, organ of Rosenmuller. Para-upophoron and Gartner's duct cyst. Okay, para-upophoron is also said to cause para-ovarian cyst, okay, which has high tendency for torsion and can be a surgical emergency. Alright, so uterovaginal canal with the urogenital sinus fusion will take place and form the cavity in the uterus, and the dissolution of the septum will take place roughly at 20 weeks. So from both the sides the fusion will take place, and finally a septum which will be developing will dissolve at around 20 weeks. A small part to remember is that the cephalic part of the urogenital sinus forms the urinary bladder, the middle part forms the female urethra, the lower or caudal part forms the vagina, or the you can say the lower one third of vagina. Upper one third, as I told, is formed a Mullerian system. Also, the lower one third gives lower part of the urogenital system gives rise to the Skene's gland and the Bartholin's gland. Okay. Now in this image I have taken from Williams Gynac, you can see the same thing they have highlighted, that once there is a fused Mullerian duct, this is the urogenital sinus, which is the yellow part. Okay, so both of them are going to fuse. Alright, this and this have to fuse. So this is the development of the lower female reproductive tract. The fused Mullerian duct joins the urogenital sinus. Okay, from the urogenital sinus, the sinovaginal bulbs evaginate and proliferate cranially to create the vaginal plate. So as I said, the vaginal canal has to be formed. Okay, so once there is canalization, this leads to the development of lower vagina. So you can see that the vaginal plate is being formed, okay, from the sinovaginal bulb. So there will be a canal type of formation, and the upper vagina develops from caudal end, okay, and this develops from the Mullerian ducts. Also, let me show you another diagram. Now this is taken from Spirov. So this is the same thing which I have explained already. When there is an undifferentiated form, we have, these are the gonads which will develop from the gonadal ridges. Now this is your mesonephric duct, which is also known as the Wolffium duct, and this is the paramesonephric duct, which is known as the Mullerian duct. Okay. So once there is regression of the Wolffian duct because of the absence of the SRY gene due to the lack of Y chromosome, there will be the regression of the Wolffian system, and there will be development of the Mullerian system. Okay, so once there is development of the Mullerian system, it will give rise to the fallopian tube, the uterus, and the upper two-thirds of the vagina. Ovaries develop from the genital ridge. These are the mesonephric remnants. Okay, as I said, the epophoron, paraepophoron, all these are the remnants of the mesonephric duct. And if there is a Y chromosome, this will give rise to the male internal genitalia. Also, this is another image which I have taken from Novak's. So you can see the comparative changes of male and female during early embryonic development. So if you see, these are the uterine tubes, that is nothing but the fallopian tubes, and the uterus and the vagina, and these are developing in close relationship to the urinary system. Okay, if you see the early part, you'll see this is the degenerating paramesonephric duct and the degenerating mesonephric duct. These are converting into the mature forms. Okay, so epophoron from the degenerating mesonephric duct. This is the oviduct, also known as the fallopian tube, and this is the fimbria. This is how embryologically it's developing. These are the paraepophoron, which are remnants of your the Wolffian system. Okay. Now that we have understood the embryology of Mullerian system, it becomes now easier to learn about the classification. Now, the classification of Mullerian anomalies have been given differently by the different societies. So first we shall be discussing about the classification given by the ESHRE. So this is the ESHRE guidelines which have been given, and this is an update. So remember, so this divides basically the Mullerian anomalies into 6 classes. Okay, you can remember, since it's a European society, it is all under the nomenclature of U. Okay, so U0 stands for normal uterus, then U1 is dysmorphic. Under dysmorphic you have T-shaped, infantile, and others. U2 is called septate. Septate can be partial or complete. U3 is bicorporeal, which can again be partial, complete, or bicorporeal septate. U4 stands for hemiuterus. Now in this we are talking about the rudimentary horn. Then, so the rudimentary cavity can be present, that is with or without. Next, U5 is the aplastic uterus. The aplastic uterus again can have rudimentary cavity or may not have, so with or without. And U6 is the unclassified cases. So under the ESHRE guidelines, the anomalies have been classified into uterine anomaly, cervical anomaly and vaginal anomaly. Remember that all the uterine anomalies come under the main class and they are given under the nomenclature of U. So as I told you, 0, 1, 2, 3, 4, all these are the main class. The further subdivisions that I told, these are known as the subclass. Next comes the cervical or the vaginal anomalies, and these are the coexisting class. So with the main class there may be some coexisting class. Same that C0, these are all the for the cervix, okay, cervical anomalies. The first one being the C0, that is a normal cervix. C1 is septate, C2 is double normal, C3 is unilateral cervical aplasia, C4 is cervical aplasia. Okay. Next is the vaginal anomalies. In the vaginal anomalies, we again have V0, which is normal vagina. V1 is longitudinal non-obstructing vaginal septum. V2 is longitudinal obstructing vaginal septum. V3 is a transverse vaginal septum and or imperforate hymen. Very important to remember, because these are the cases that you will encounter during your routine clinical practice, either a imperforate hymen or sometimes a transverse vaginal septum. And vaginal aplasia comes under V4. So this is the broad classification of the ESHRE guidelines that have been given. Remember, this is the European Society classification, and it gives a very detailed classification with respect to uterus, cervix, vagina, keeping uterus as the main class and cervix and vagina as the coexisting class. Now let's come to the ASRM classification. ASRM has revised it in 2021 itself. So let's talk about the ASRM classification of Mullerian anomalies. In this, you can see the first is the Mullerian agenesis. In this Mullerian agenesis, you can see Mullerian agenesis with right or left atrophic uterine remnant with functional endometrium. Okay, so you can see they have divided. So it can be agenesis, that means the cavity is not even developed, with atrophic uterine remnants with some functional endometrium. Next, this is cervical agenesis. In cervical agenesis, the cervix has not developed. This can again be cervical agenesis or distal cervical agenesis. Next is a uniconvate uterus. So you can see right or left uniconvate uterus, right or left uniconvate with right or left distal atrophic uterine remnant, right or left uniconvate with distal uterine remnant with functional endometrium. Again, uniconvate with associated atrophic uterine remnant. The other one, last one is the uniconvate with uterine horn communicating at the level of cervix. Okay, so broadly you should remember that this all comes under the classification category of uniconvate uterus. Okay, next is the uterus didelphys. Okay, so this didelphys can be with longitudinal septum, plus minus longitudinal septum of variable length. Okay, so you can see this a short vaginal septum, or you can see uterus didelphys and obstructed right or left hemivagina. Okay, this is like your overa. Okay, next is the biconvate uterus. Biconvate uterus can have again this biconvate, you can see biconvate has a serosal indentation more than 1 centimeter. This biconvate uterus can have right or left communicating tract. Again, uterus biconvate bicollis, that means there is 2 cervix and 2 uterus. Again, combined biconvate and septate uterus. So this, I think you have understood. This is your ASRM classification. American Fertility Society, that is the AFS, has also given its own classification. This image I have taken from Williams. So you can see the class 1 is hypoplasia or agenesis. It can be vaginal, cervical. In the uterus, it can be fundal or tubal or combined. Class 2 is unicornuate, which can have communicating or non-communicating, no cavity or no horn. Then class 3 is didelphys. Class 4 is bicornuate. Okay, bicornuate can be complete or partial. Class 5 is septate, which can again be complete or partial. Class 6 is arcuate, and class 7 is diethyl silbestrol related, that is DES related. Now AFS is the oldest one which we have been usually reading since a long time, and now ESHRE and ASRM guidelines have also come up in a new way. So examiners have this inclination of asking about the updates. So it's important to know not just the AFS but also ESHRE and ASRM guidelines. Now with this, I have completed the classification as well as the embryology, the development of the Mullerian system. Little bit volatile topics. I feel that you need repeated revision for this. Just you need to revise the classification of the various societies in like little more frequently before your exams maybe, and then definitely you will remember. Thank you and have a great day.